Welcome back to Clinically Clear, guys. Today we'll be covering another very clinically relevant topic, that is CSF rhinorrhea. Just as the name suggests, it is the leakage of CSF through the nose, the drain. You'd start having CSF discharge to the nose. The definition is the leakage of CSF into the nasal cavity is CSF rhinorrhea. Let's get to the etiology. 90% of the cases, the cause is trauma. Traumatic causes CSF rhinorrhea. So what could the trauma be? It could be iatrogenic trauma during any FES or during any skull-based surgery. There can be trauma induced, or non-iatrogenic trauma because of a fall, because of any car accident or anything like that. Basically what happens, there is fractures at various location of the skull base that leads to CSF leakage. Where? Let's look at the sites of the CSF leakage. The most common site is the thinnest part of the skull base, that is the cribriform plate. The most common cause is cribriform plate fracture. That is where the CSF leaks from the anterior cranial fossa. So anterior cranial fossa leak is because of cribriform plate fracture, which is the most common cause. Now cribriform plate is not just a straight plate. It is in the form of it has two lamellae. It has a lateral lamellae and a medial lamellae. This is cribriform plate on one side, this is on the other side. So you have a lateral lamellae and a medial lamellae. Now, the lateral lamellae is very thin. The lateral lamellae is very thin and it articulates with the fovea ethmoidalis. What is this fovea ethmoidalis? This fovea ethmoidalis is a very thick bony roof of the ethmoid sinus. It is a part of the frontal bone. Cribriform plate is a part of the ethmoid bone. Remember, cribriform plate is a part of the ethmoid bone. This fovea ethmoidalis, which forms the roof of the ethmoid sinus, is a part of the frontal bone. This is a very thick bone. It does not get fractured easily. No, the cribriform plate is what gets fractured. In the cribriform plate, it is the lateral lamellae that is most commonly fractured. Why? Number one, lateral lamellae is thinner than medial lamellae, and the lateral lamellae articulates with this frontal bone. So it forms a joint. Wherever you have a joint, there's a high chance of fracture or weakness, right? That is why it is a lateral lamellae. So the most common leak is from the anterior cranial fossa due to trauma to the cribriform plate. Now, there is something known as Keros classification. Basically, Keros classification checks whether, based on the depth of the olfactory fossa, this fossa formed here. See, this is the nasal septum. This fossa formed here by the cribriform plates on both the sides is known as olfactory fossa. Now, the depth of this olfactory fossa can differ. Keros classified them into type 1, type 2 and type 3. Type 1 is low depth cribriform plate, 1 to 3 mm. Type 2 is moderate depth, 4 to 7 mm. Type 3 comes under high depth olfactory fossa. The cribriform plate is very low lying. It can be 8 to 16 mm below. So because of that, what happens during FES, during any skull base surgery, there is high likelihood that the cribriform plate can get injured. Because it is much more low lying, there is a higher risk of trauma causing cribriform plate fracture. So this is the anterior cranial fossa leak, which is the most common cause for CSF rhinorrhea. Trauma leading to fracture of the lateral lamella of the cribriform plate, causing CSF leakage from the anterior cranial fossa. Now, CSF can also leak from the middle cranial fossa. From the middle cranial fossa because of two fractures, fracture of the sphenoid bone or because of something known as transverse temporal fracture. Now, how does transverse temporal fracture lead to CSF rhinorrhea? Basically, when there is transverse temporal fracture, there is CSF leakage into the middle ear. From the middle ear, via the eustachian tube, it comes into the nose, leading to CSF rhinorrhea. So that is transverse temporal fracture. So either it can be because of sphenoid bone fracture or it can be because of transverse temporal bone fracture that can lead to CSF leakage from the middle cranial fossa. Next, coming to, so this is the traumatic cause. 90% of the time it is traumatic cause. Then coming to 10% of the time, CSF rhinorrhea is because of non-traumatic causes. Now, non-traumatic causes, it can be two types. It can be because of high pressure CSF leaks or normal pressure CSF leaks. In high pressure CSF leaks, what happens? Because of very high CSF pressure, it starts eroding the bone of this, eroding the skull base bones. Because of gradual erosion of the bones, eventually there's a leak leading to CSF rhinorrhea. What can lead to increase in CSF pressure? There is a disease known as benign intracranial hypertension. that can cause. And also any intracranial tumor, space occupying tumor, it'll take up a lot of space. This will increase the pressure exerted by CSF on the bones, so it will erode the bone. So this is high pressure CSF leaks. Whereas no low pressure CSF leaks can be because of various other causes, like congenitally the skull base is very, very weak, or osteomyelitis infection of the skull base, or it could be because of any tumor eroding the skull base. And there is also some condition known as empty sella syndrome. What is this empty sella syndrome? Basically, here you have the sphenoid sinus, right? Roof of the sphenoid sinus, you have a depression known as sella turcica. So, within the sella turcica, normally you have the pituitary gland. But what happens? There is CSF herniation into the sella turcica. CSF enters the sella turcica. This applies pressure on the pituitary gland, leading to ischemic necrosis of the pituitary gland. So eventually what happens? The sella turcica is filled with CSF. This CSF gradually erodes the sphenoid bony capsule known as sella turcica, and the CSF leaks into the sphenoid bone, leaks into the sphenoid sinus, and eventually into the nasal cavity. So you have traumatic causes from the anterior cranial fossa because of cribriform plate fracture, lateral lamina cribriform plate fracture, which is the most common type, or from the middle cranial fossa, trauma leading to either sphenoid bone fracture leading to CSF rhinorrhea, or transverse temporal bone fracture where CSF leaks into the middle ear first and then via the eustachian tube into the nasal cavity. 90% of the time it is due to trauma. 10% of the time non-traumatic causes. High pressure CSF leak causing bone erosion such as benign intracranial hypertension or any intracranial tumor, or it could be low pressure, actually not low pressure, normal pressure. Normal pressure CSF leaks, which can be because of congenital weakness of the skull base, or any osteomyelitis of the skull base, or any tumor eroding the skull base, or empty sella syndrome where CSF herniates into the sella turcica. So this is about etiology. Then symptoms, basically commonly misdiagnosed as allergic rhinitis because of unilateral watery nasal discharge. When the patient leans forward, there is dripping of fluid, watery fluid down the nose. This is usually unilateral, whereas allergic rhinitis, you'll have bilateral watery nasal discharge. But that is very important to remember. This is normally unilateral. CSF rhinorrhea is unilateral. Unilateral watery nasal discharge upon leaning forward. Then, what are the signs of CSF rhinorrhea? The signs are, number one, it has a metallic taste. Then, sniff back test negative. See, normally our nasal discharge, nasal mucosal discharge, we are able to sniff it back. But then, in case of CSF rhinorrhea, it is continuously leaking. You cannot sniff it back. So sniff back negative. And handkerchief test. When you have nasal mucosal discharge on a handkerchief and you let it dry, eventually there is a formation of a crust on the handkerchief. But in case of CSF rhinorrhea, there is no crusting. Then there is something known as reservoir sign. What is reservoir sign? You make the patient lie down in supine position. When the patient lies down in supine position for a few minutes, the CSF that is leaking starts to collect in the sphenoid sinus. Then you suddenly ask the patient to get up and lean forward. There is a gush of CSF through the nostrils. Why is that? All the collected CSF from the sphenoid sinus starts flowing out. This is known as reservoir sign. The sphenoid sinus acted as a reservoir of CSF. If what did I tell is the most common cause of CSF rhinorrhea? That is trauma, right? 90% of the cases it is trauma. So there can also be bleeding through the nose. There can be epistaxis. So if CSF rhinorrhea is mixed with blood, then there is a classical sign which can be seen on the clothes of the patients, etc., known as double ring sign or target sign or halo sign. As you can see in this picture, double ring sign, target sign or halo sign. So what is the symptom? Unilateral watery nasal discharge upon leaning forward. You cannot sniff it back. It has a metallic taste, reservoir sign, double ring target or halo sign, and handkerchief. It does not cause any crusting. Then coming to the investigations. See, the best biochemical investigation is beta-2 transferrin or beta trace proteins. This beta-2 transferrin or beta trace proteins, it is only present in the CSF, absent in nasal discharge. Then, let's say I want to assess the site of the leak. If I want to do a surgery, I need to know where the CSF leak is first, right? For that, the best investigation is high resolution CT. High resolution CT, you can exactly get to know, oh, this is cribriform plate fracture, this is sphenoid bone fracture, etc. But You can also have use other methods such as intrathecal fluorescein test. We put an intrathecal injection of fluorescein dye. What does it come? It comes up all the way to the CSF. Now the CSF contains the fluorescein dye. Within the nasal cavity, we place various cotton buds. So what happens during active leak? During active leak, along with the CSF, the dye also leaks out, and whichever cotton bud stains yellow color basically takes up the dye. That is where the CSF is leaking. So that is intrathecal fluorescein test. Similar method, but via radiologically, if you inject contrast dye into the CSF, basically intrathecal contrast injection, it comes up to the CSF, and then what happens? You can do MRI cysternography. MRI cysternography, you can see where exactly the leak is. But this MRI cysternography is also relying on the dye leaking out, and intrathecal fluorescein test is also relying on the dye leaking out. So it is only during active leak. But if you want to see the fracture on an X-ray or like on a radiographical film, then the best investigation to see the site of the leak is high resolution CT. Then coming to the management. See, any opening that has been created in our body tends to heal it by itself. So for the first 2 weeks, we always go for conservative management. Conservative management to allow for the uh, CSF leak to heal by itself. But during this conservative management, for proper healing, we should reduce the pressure, the CSF pressure at the site of the leak, so that there is very less leakage. So how do we do that? We ask the patient not to strain. We give them laxatives, stool softeners, we give them cough syrups, etc. And also, to prevent any nasal infection from spreading to the meninges and leading to meningitis, we give prophylactic antibiotics. And we ask the patient to sleep in a propped up position, so that there is a reduced CSF pressure at the site of the leak. Not in supine position, but propped up position, to reduce the pressure at the site of the leak. But let's say even after 2 weeks of conservative management, patient is still having unilateral watery nasal discharge, patients, there is still CSF rhinorrhea. Then you can go for surgical repair of the site of CSF leak, such as transnasal endoscopic approach, which is the most preferred method. Transnasal endoscopic approach to fix the CSF leak, or you can go for external approach, open approach to fix the CSF leak. So for 2 weeks, conservative management to allow for it to heal by itself, reduce the pressure by propped up position, and by giving stool softeners, cough syrups to reduce straining, give prophylactic antibiotics to prevent meningitis. If it still doesn't work, go for surgical repair of the site of the leak via transnasal endoscopic approach or via external approach. That is it for CSF rhinorrhea. I hope you guys enjoyed the video. I think I fumbled a bit in the middle where I was not very smooth. I'll apologize. I'll try to do better next time. Thank you for watching.